I'm Harriette Van Spall, Associate Professor of Medicine from McMaster University and Principal Investigator of the PACT-HF trial. I'm here with Dr. Jozine, who's a cardiologist at the University Medical Center in Groningen. She's presenting the renal endpoints of the STRONG-HF trial that was led by Professor Alex Mabaza from France. And with us is Dr. Tariq Ahmad, who is Chief of Heart Failure and Associate Professor of Medicine from Yale. He's the principal investigator of the PROMPT-AHF trial, and we are presenting the results from these three trials at Heart Failure Association 2023 in Prague. We would like to focus our discussion today on hospitalization for heart failure. More than 56 million people across the world live with heart failure, and a majority of them are hospitalized at some point in their disease course. Hospitalization is a high-risk condition. We are going to discuss three approaches that aimed to improve outcomes during and after hospitalization, either through the improvement of guideline-directed medical therapy or healthcare services. And so I'm going to begin by inviting Dr. Tariq Ahmad to discuss the PROMPT-AHF trial, give us a bit about the rationale, the methods, and then the results. Welcome, Tariq.
Absolutely, Harriette. Thank you so much for having me. So, PROMPT-AHF was born a few years back when we realized that clinicians are busy, and if we wanted to use the electronic health record to its purpose, we can give them alerts about best practices for their patients. So we designed a clinical trial in the outpatient setting across the Yale New Haven Health System, which is a massive academic healthcare system in Connecticut, where we did a cluster randomized trial of outpatients with outpatient clinicians who saw patients with heart failure with reduced ejection fraction, and we gave them personalized recommendations about what medications their patients should be on. As you know, guideline-directed medical therapy has gotten quite good in the last decade or so. It improves quality of life. It improves patient outcomes. And we also know that the vast majority of patients are not on appropriate guideline-directed medical therapy. So we did this randomized controlled trial in the outpatient setting, and this was presented at ACC last year, and showed a fairly dramatic improvement in guideline-directed medical therapy. Of course, you wrote the editorial for the manuscript, which was incredibly well written and put everything into good perspective. Along the same time, we asked the question, patients in the outpatient setting, we do need to get them on better medical therapies. But what about those patients who are admitted to the hospital? We know that those patients have incredibly high rates of readmission and death. And we also know that patients who are admitted with heart failure with reduced ejection fraction, for the most part, are not started on guideline-directed medical therapy. So we asked the question, what if we use the same approach in terms of the alert in the outpatient setting? And we did this for patients who were admitted for acute decompensated heart failure. And that was the PROMPT acute heart failure trial. So the trial randomized at the patient level across our big healthcare system, 1,012 patients to the patients who were randomized to the personalized alert arm. The clinicians taking care of them while they were putting in orders were alerted about, this is your patient with heart failure with reduced ejection fraction. This is their ejection fraction, their creatinine, their NT-proBNP levels. And these are the medications that they are on, that they should be on, and these are the medications that they should be on, with an order set that allows them to place patients on these medications. What we found, quite surprisingly, and this was very different from what we found on the outpatient side, was that this alert made no difference. And the number of patients, the primary outcome obviously was the number of patients in whom a guideline-directed medical therapy was added at time of discharge. And this outcome was equivalent in both the arm of patients who were randomized to their clinicians getting the alert versus the usual care arm. And we also found that only 11% of patients were discharged on all 4 pillars of guideline-directed medical therapy. So I find this result quite fascinating. In fact, it's even more fascinating than a positive result in the outpatient setting, because as clinicians realize, patients admitted for acute heart failure have several different, physicians and clinicians working on them. There is a sense that we're going to be taking care of the acute issues, and starting patients on guideline-directed medical therapy is a outpatient issue, or someone else is going to be able to deal with that. And we think that this is one of the reasons why this was not a positive trial like it was in the outpatient side.
Absolutely. Thank you for that overview of your trial and the results. And we're going to come back for some discussion at the end. I'm now going to invite Dr. Jozine Ter-Martin from the Groningen Medical Center to discuss with us the sub-study that focused on renal endpoints among those who participated in the STRONG-HF trial. Perhaps you could give us a one-liner on the algorithmic-driven approach of the trial and its primary outcome that was presented last year, and then add on this sub-study.
Yeah, thank you so much for the introduction and the invitation to be here. And I would also like to take this moment to thank the STRONG-HF investigators for the opportunity to have me do the renal function analysis and present the results at HFA Congress. To briefly come back to the STRONG-HF. So as we probably are all very familiar with now, the STRONG-HF trial enrolled patients that were admitted to the hospital for acute heart failure to either high-intensity care. So these patients were randomized before discharge to high-intensity care or usual care. And in the high-intensity care group, patients were to receive half of optimal doses of guideline-directed medical therapy before discharge, and then they were quickly up-titrated within 1 to 2 weeks to full doses of guideline-directed medical therapy, whereas in the usual care group, the up-titration was done according to the common local practices. And the study was even halted early for overwhelming benefit of the high-intensity care on the combined endpoint of all-cause mortality or heart failure hospitalization. So overall, very important and novel findings. But as I think we are all very aware of, renal function is often diminished in patients with heart failure, and especially acute heart failure. And also most of our guideline-directed medical therapies also affect renal function. So we often see clinicians struggling how to negotiate the changes in renal function and the up-titration of the guideline-directed medical therapy, even though there's even strong evidence that some of the therapies have renoprotective effects in the long term. So what we looked at in this analysis of the STRONG-HF trial is the effect of both baseline renal function on outcomes, but also changes of renal function during the high-intensity care. This is also one of the limitations of the trial, because renal function at the subsequent weeks was only assessed in the high-intensity care group, so not in the usual care group. So we were not able to compare the changes in both groups. So what we found is that the effect of the high-intensity care group, the positive effect of this on outcomes, was independent of baseline renal function, and the effect was maintained regardless of baseline renal function. Even though the eGFR was 30 or 90, there was still a very positive effect of the high-intensity care treatment strategy. Then we looked at a decrease in eGFR, so of more than 15% from baseline to week 1. And we chose this cutoff as this is more than you would expect during up-titration of guideline-directed medical therapy. And it's very important that the protocol only stated that guideline-directed medical therapy should not be further up-titrated if eGFR fell below 30. But what we saw is that even though there weren't a lot of baseline differences in patients who had a decrease in EGFR, we did see that patients who had a decrease in EGFR of 15% or more at week 1 had a more increase in NT-proBNP at this time point, and also at the following visits, so from week 2, week 3, and further down the road, received lower doses of guideline-directed medical therapy. So we did see an association between decreasing EGFR and low and poorer uptitration of guideline-directed medical therapy. The decrease in EGFR was, however, not associated with poor outcomes, but it could very well be that we were underpowered because we did see a hint of more heart failure hospitalizations in patients who had a decrease in EGFR. So to conclude, I think our analysis showed that guideline-directed medical therapy and swift uptitration has a good effect regardless of baseline renal function. And I think our analysis also shows, even though we're not able to show causality, that it's always important to look at the cause of a decrease in EGFR, because we did see, or at least found a hint towards an association with congestion. And we feel that the decrease in EGFR should not necessarily be a reason to stop uptitrating.
Right, and your presentation nicely highlights the paradox that kidney disease portends a poor prognosis, and yet it is a reason that limits the optimization of therapies, even though patients across renal function benefit from those very same therapies. I'm now going to present the PACT-HF trial that I led. This was a strategy of transitional care interventions to improve outcomes following hospitalization for heart failure. We all know that hospitalization is a high-risk condition, followed by a 25% risk of readmission, a 4 to 5% risk of death in the weeks following hospitalization. The PACT-HF trial was based on evidence garnered through a network meta-analysis that we had led that demonstrated that heart function clinic visits and nurse home visits improved outcomes among those who were hospitalized for heart failure. We packaged these interventions and delivered them in a pragmatic setting across hospitals in Canada. Patients who were hospitalized for heart failure were provided self-care education, a patient-centered discharge action plan, a follow-up with their primary clinician within a week. And if they were at high risk of readmission or death, we offered them home care nurse-led visits within a week of discharge, continued on for 4 to 6 weeks, and heart function clinic visits that were offered within a month of discharge and continued indefinitely. The primary outcome was measured at 3 months following discharge, and we presented this at ESC a couple of years ago. The intervention had a neutral effect on the primary composite endpoint of all-cause death, readmission, or emergency department visits at 3 months, although it improved patient-reported outcome measures that included health status and quality of care transition. The aim of this analysis, given that the heart function clinic visits continued indefinitely following discharge, was to test the effect of the intervention on the primary composite endpoint of all-cause death, readmission, or emergency department visits at 3 years, because we knew there would be higher event rates and more power to demonstrate whether optimization of care in these heart function clinics would translate to improved clinical endpoints. This was a stepped wedge cluster RCT of 10 hospitals that crossed over from usual care to intervention in a randomized fashion. We adopted a pragmatic approach. The primary clinical endpoint was a composite of all-cause death, readmission, or emergency department visits, and the secondary endpoint was a component of these primary clinical endpoints, along with heart failure hospitalization. We also looked at the uptake of guideline-directed medical therapy and the uptake of the implementation intervention itself. We found that patients were balanced in terms of their baseline characteristics in both groups, with a mean age of 78 and 50% were female. They were complex in their comorbidities, reflecting the pragmatic nature of the inclusion criteria. We found that the intervention did not reduce the primary composite endpoint at 3 years, and that there were no sex differences or age differences in the treatment effect. We also conducted an on-treatment analysis. The primary analysis was, of course, intention to treat. And we found that the on-treatment analysis was also neutral. So adjusting for crossovers and suboptimal fidelity to the intervention, there was still no treatment effect with the intervention on the primary composite endpoint. Accounting for death as a competing risk, however, we found a significant reduction in heart failure readmission at 3 years. This is, of course, hypothesis generating. It was an exploratory endpoint and the multiplicity was not adjusted for. But accounting for death as a competing risk, there was still no reduction in all-cause readmissions. And there was a large numeric reduction, but not quite statistically significant, in the endpoint of all-cause emergency department visits. The implementation outcomes demonstrated that there was an increase in the uptake of heart function clinic visits in the intervention group, which is exactly what we were hoping for, but that the nurse home visits were also offered to the usual care group. So some evidence of contamination. But as I said, the on-treatment analysis was also neutral. We found no substantial difference in the uptake of guideline-directed medical therapy in both groups, with the exception of an increase in the use of ARNIs in the intervention group. But overall, the uptake of ARNIs was very poor, about 3% in the intervention group and 1.5% in the usual care group. So in summary, a transitional care intervention that offered heart function clinic visits at the time of discharge indefinitely did not reduce the primary composite endpoint of all-cause death, readmission, or emergency department visits, although it did reduce heart failure hospitalizations when accounting for death as a competing risk. There was some contamination, but the on-treatment analysis was consistent with the intention to treat analysis. So let's open this up to discussion. 3 different types of intervention. One was an electronic health record prompt to clinicians who were the inpatient providers. My first question to you, Tariq, is how many clinicians received these alerts? Was it just the MRP, or were all clinicians involved in the care of these patients provided the alerts? And were the alerts general, such that people knew what therapies the patients should be on that they weren't on, or were they specific? So, for example, add carvedilol 3.125 milligrams twice a day. Can you let us know about the intervention?
Absolutely, Harriette. So the interventions were targeted at clinicians who were placing orders. So if you're an ID consultant, for example, going into someone's chart, we did not want to burden you with this alert. So it was primarily, or it was triggered by the clinicians who were putting in orders for their patients. So they're taking care of the patient. Now, the alerts were personalized. So they gave you the information on that patient in terms of what, the creatinine was, the blood pressure, the heart rate, the ejection fraction, all those things that clinicians take into account when they're deciding what medication the patient should be on. It also said that these are the medications that the patients are already on that they qualify for. For example, if they were on a beta blocker that was evidence-based, it said they're already on Coreg, they're on Entresto, for example, but they should be on an SGLT2 inhibitor and an MRA. And then the order set was specific to those medications that they should be on. We also took into account where if the patient's GFR, for example, was too low, then we did not recommend medications that are contraindicated for that particular patient population. Or if their heart rate is too low, they didn't get recommended to be on beta blockers. So it was entirely personalized to the patient that clinician was taking care of.
So that's really interesting that it was it made the next step so easy for the clinician, and yet No difference. Now, is it because the therapies weren't, or the instructions or the alerts weren't adhered to? Or did you find that there was fidelity and adherence to the recommendations, but nevertheless, no change in the uptake of therapies?
So that's a really good question. So we found that about 15% of providers who were alerted accepted the alert. So the acceptance rate was less than what we found in our outpatient study, which was roughly 25%. So it was less. But when you looked at the patient level, about 71% of the patients had someone accept the alert. So someone putting in orders accepted the alert. So the coverage per patient was far greater than what we saw on the outpatient side. But what we found was that they would accept the alert and then just ignore the results. So they were like, yes, I know this patient should be on these medications, but you know what? Maybe someone else should be responsible for starting them. And this is kind of a behavioral economic issue, right? This diffusion of responsibility that occurs during the inpatient stay, where it's like, I could start the patient on SGLT2 inhibitor, but, it wouldn't matter if I did or not. So I'm not going to take the responsibility. Maybe someone else will. And we found this in other studies where in, secondary prevention study that we did called PROMPT-Lipid, when we would alert, the primary care doctor, they would say the cardiologist should put the patient on a statin, and then the cardiologist would say the primary care physician should put them on statin. So this is something that's well known in the literature about how human beings act when they're told to do something. I think we're very good at not taking responsibility when we don't have to.
Sure. So perhaps a role in some qualitative analysis to tease out some of the reasons why some of the alerts were overridden. Jozine, my question to you has to do with the algorithms that were provided to clinicians as part of STRONG-HF. Could you spend a few seconds telling us about that approach?
So for patients in the high intensity care group, they were seen at the outpatient clinic at week 1, 2, 3, and 6. And then at that time point, laboratory values such as creatinine, but also NT-proBNP, but also blood pressure, heart rate was assessed. And then per protocol, because I think that's what you're referring to, the systolic blood pressure, if it was below 95 or eGFR below 30, limitations of certain guideline-directed medical therapy of further up titration was defined. But there were no other cutoffs that were defined in advance. So what we observed in my analysis is that if there was a decrease in eGFR greater than 15%, because most patients had a baseline eGFR around 65, that was the median. So this decrease would not have led to an eGFR below 30 in the great majority of patients, but still it led to clinician hesitation to further up-titrate the patients.
Right, and perhaps we should say that there's a difference in the study design. I would classify PROMPT-AHF as more pragmatic, where these directive alerts were sent to clinicians, but they were allowed to use their clinical judgment. I would classify STRONG-HF as slightly more explanatory, where research units were used, or the algorithmic approach was delivered through a more explanatory setting rather than a pragmatic setting. But what's remarkable to me about STRONG-HF is that it was a multinational, multi-center trial, whereas most of our implementation trials tend to focus on single healthcare systems. PACT-HF was a multi-center trial as well, but it was contained within a Canadian single-payer healthcare system. But to me, these results sort of highlight that open-ended care pathways don't tend to be successful. So services may improve the patient's experience of care, but leaving adjustments to clinicians aren't the best way or an effective way of improving the uptake of medical therapies. Then again, providing directive alerts aren't always effective, and it may be because in the inpatient setting, There's not a defined person that's going to follow the patient through the duration of their healthcare journey. And there's this perception that you're putting out a fire, you need to stabilize somebody and then send them to somebody else. And how does that compare to strong HF in your mind, Jozine?
Yeah, exactly. Yeah. So they were up titrated to half of guideline-directed medical doses before discharge, and after that, it was the outpatient setting. And I think what Tariq nicely highlighted is that in hospital, maybe the physicians don't feel the responsibility, whereas in the outpatient clinic, they definitely feel the responsibility more, and especially in strong HF, where patients randomized to this group were intentionally seen more frequently and up-titrated. And as you refer to, I think it's a credit to the strong HF investigators of all the countries they were able to include, because it was so diverse. And I think that's also one of the reasons why this study is so powerful and impactful.
Sure, although we should mention that patients were included only if they had suboptimal therapies to begin with.
Yes.
So there's a bit of a more stringent eligibility criteria, which makes the intervention more likely to be effective. Well, thank you both for joining me in this exciting discussion about hospital to home transitions. We look forward to having more interactions during this meeting and wish you well on your presentations. Thank you so much.
Thank you so much, Harriette, and congratulations to Jozine as well. This is great, really incredible work.